We will go to the third speaker of the day, Mrs. Aparna Marthi. Mrs. Aparna Marthi is a clinical nutrition manager and registered dietitian nutritionist, Oak New York. Madam Aparna obtained her undergraduate and master's degree in food science and nutrition in the year 1991 from Sri Sathya Sai Institute of Higher Learning. Following Swami's principle, Aparna Madam was a homemaker for 14 years, raising her two boys before she went back to do her dietetic internship in the year 2005 at Russell Sage College in Troy, New York, and Vassar Brothers Medical Center in Poughkeepsie. Aparna obtained her registered dietitian credentials in 2008. She worked as a dietitian at VBMC from 2006 to 2007 and moved on to work as a registered dietitian at Lutheran Care Centre. LCC is a 160-bed facility catering to the seniors in the community. She has been working at LCC for the last 13 years and has assumed the role of clinical nutrition manager since 2018 to the present. Aparna is actively involved in biannual health fairs organized by local Sathya Sai Center of Bacchus Falls, New York. Madam will be speaking to us on the topic feeding options for the elderly in COVID scenario. The sky is the limit. Please welcome Madam Aparna. Over to you, Madam.
Sairam, my name is Aparna Marthi. I'm a clinical dietitian working in a long-term care setting in Poughkeepsie, New York. I'm going to be talking about feeding options for the elderly in COVID scenario. Sky is the limit. I'm also going to be touching upon oral nutrition supplements, enteral nutrition, and parenteral nutrition. Good nutrition, as you know, is a vital part of patient care. It includes nutritional screening, assessment, and intervention. Nutrition intervention involves many strategies: food, oral nutrition supplements, tube feeding, or parenteral nutrition, or TPN. Oral nutrition supplements, as you know, are important as nutrition intervention for patients with poor food intake, low appetite, and those with or at risk of malnutrition. Oral nutrition supplements improve the nutrition status of patients by giving them adequate calories, protein, and micronutrients. They usually come in small volume options such as 8 ounces, 6 ounces, or 4 ounces. A number of commercial supplements are available for adult patients and residents, and we have 2 suppliers that we use in our nursing home. One is the Abbott Nutrition. They usually supply us with Ensure products, can be Ensure Pudding, Ensure Clear, Glucerna, Nepro, 2-Cal-HN. And some of the supplements are from Hormel Health Labs. That's another supplier that we use. And they usually provide us with Mighty Shakes, Magic Cups. Ensure Shake can be used for patients who are malnourished or experiencing involuntary weight loss. Ensure Clear is a clear drink for patients who prefer a fruit-flavored alternative to a creamy shake-like supplement. Ensure Pudding is alternative to snacks or desserts that provide balanced nutrition, especially for patients on food-restricted or volume-restricted diet or consistency-modified diets. Glucerna shakes and snack bars help minimize blood sugar spikes, especially in diabetics. Nepro with Carb Steady is a supplement designed for patients on dialysis. 2-Cal-HN, HN is high nitrogen, is designed for high protein and caloric need of patients requiring low volume feedings in 2 fluid ounces or 60 ml volumes. Typically, it is being given as a MedPass program in between meals with the medications so as not to interfere with the meals. Mighty Shakes are again, protein and calorie dense. They come in 4 ounces, 6 ounces servings in nectar thick or honey thick consistencies. Magic Cups are also protein and calorie dense. Magic Cup is like an ice cream when consumed frozen. After thawing, it appears as a pudding. So therefore the name magic. They come in different flavors and 4-ounce servings. Let's look at some pros and cons of using oral nutrition supplements. Pros are they increase energy and protein intake along with micronutrients. They have clinical benefits in improving weight, reducing complications such as pressure injuries, reduce mortality and hospital readmissions, and it's non-invasive. It doesn't require any tube. They help improve quality of life. They have proven nutritional, functional, clinical, and economic benefits by reducing healthcare costs. The cons are they decrease the intake of normal food if not used appropriately or overprescribed. They can increase food supplement costs if overused, can have poor compliance from patients if not monitored properly. Some patients and residents may not like the taste of the prescribed supplement. Let's look at nutrition support. Nutrition support is a provision of nutrients to patients who cannot meet their nutritional requirements through consumption of standard diets. To meet the energy requirements for metabolic process is the goal. Who are the candidates for nutrition support? Post-op complications. Those are severely malnourished, those are burns, trauma, malignant disease, short bowel syndrome, renal or liver failure, prolonged ileus, intestinal obstruction, pancreatitis, major bowel surgery, esophageal surgery, gastric colon surgery, Whipple's procedure. Let's look at algorithm for nutrition support. This is an easy way to find out who needs nutrition support. You have to first look at the nutrition status. Is it adequate? If it's adequate, okay, give them the oral diet, and you need to assess their nutrition status. You have to look at the GI tract. Is it functioning? If it's functioning, is the appetite satisfactory? And are they able to physically eat? If it's yes to all the questions above, then you say, okay, oral diet, give them oral diet, supplement as necessary. If you feel that they're not meeting their needs, then if the intake is adequate, go to enteral nutrition by tube feeding. And if you look at the nutrition status, and if you feel from the get-go that they're not meeting their needs, you have to give them nutrition support. You have to select an appropriate feeding route. You have to look at their GI tract. Is it functioning? No. If it's not functioning, okay, you have to look based on their severity of disease and doctor's advice. You have to look at give them short-term support, or, for example, you can give parenteral nutrition by peripheral vein. And if they require long-term nutrition, you got to give them parenteral nutrition by central vein. So if you look at the algorithm here, the GI tract is the gut is the main thing. If you got to look at it, is it functioning or not? That's when you can find out if the patients need enteral nutrition or parenteral nutrition. Enteral nutrition is the method of feeding a patient through a tube that enters their body, which is also known as tube feeding or feeding tube placement. An nasogastric tube is placed into the stomach through the nose, or a gastric tube is inserted surgically into the abdomen, either in the stomach or jejunum. Now, who are the candidates for tube feeding? People with extremely high nutrient requirements, those who are on mechanical ventilation, people with neurological disorders or coma, severe swallowing disorders, little or no appetite for extended periods, certain types of intestinal surgeries, GI obstruction and fistulas, impaired motility in the upper GI tract. I just wanted to show you pictures here of feeding routes. Look at the picture on the left. You have the nasogastric placement. The tube goes from the nose into the stomach. And if the tube goes from the nose into the duodenum or the jejunum, it's nasoduodenal or nasojejunal feeding. And the ostotomies are surgical procedures where the tube is directly placed into the stomach. It's called gastrostomy. When the tube is surgically placed into the jejunum, it's called jejunostomy. Selecting a feeding route based on feeding duration. If a patient requires short-term feeding, 4 weeks or less, nasogastric or nasointestinal route is used. Feeding tube, like I mentioned earlier, is passed into the GI tract via the nose. The feeding tube tip is placed in the stomach for nasogastric and in the small intestine for nasoduodenal or nasojejunal feeding. Long-term is usually for more than 4 weeks, usually via the gastrostomy route or the jejunostomy route. And selection of feeding tube depends on the patient's age, patient's size, feeding route, and the formula's viscosity. There are different types of enteral formulas. Standard formulas, patient can digest and absorb nutrients without difficulty. There are elemental formulas, patients who have compromised digestive absorptive functions. Specialized formulas meet the specific nutrient needs of patients with particular disease, and modular formulas, patients who require specific nutrient combinations to treat their illness. More often in our nursing home, we usually give the residents standard formulas. Rarely do we give them elemental formulas or specialized formulas. And the modular formulas are usually, they have one macronutrient, for example, carbohydrates, or they just contain protein or fat, depends on the patient's needs. And the composition of the macronutrient in protein can vary from 12 to 20% of total kilocalorie. Carbohydrate is 30 to 60% of kcal, and fat is 50 to 30% of the total kcal. Energy density varies. It's from 1 kcal to 2 kcal per ml of fluid. A typical example of 2 cal is 2 cal HN that we use. Fiber content varies. Formulas with or without fiber depends on the digestive capacity of the resident or the patient. And also formulas depend on the osmolality. There's isotonic formulas, there are hypertonic formulas, but most enteral formulas are between 300 to 700 milliosmoles per kg, and that is equal to the osmolality similar to blood serum, which can be easily tolerated by the patients. Formula selection, as I mentioned, is based on GI function, nutrient energy needs, fluid requirements, need for fiber modifications, individual tolerances, food allergies, and sensitivities. The two types of feeding systems, closed system and open system. Closed system formula is pre-filled by manufacturer into feeding container. It has reduced handling, decreases risk of microbial contamination. Most closed systems can hang for 24 to 48 hours. Open system formula is decanted from the original container into feeding reservoir. A ready-to-use formula is good for 8 to 12 hours. Reconstituted formula with modular components is only good for 4 hours. Typically, we use closed system. We get the formulas pre-filled by the manufacturers, and they usually hang for about 24 to 48 hours. The different kinds of delivery methods, bolus feeding. A large volume is given for about 250 ml, or a cup is given over 10 to 20 minutes, 4 to 6 times a day. This is best used for gastric feeding and patients who are stable. Intermittent feeding is a large volume. It's about 200 to 500 ml is given over 60 to 75 minutes, 5 to 8 times a day. This is best used for gastric feeding of patients with normal gastric function. Cyclic feeding is a prescribed amount of formula given for a specific period of time that is usually less than 24 hours, typically used when transitioning to an oral diet or often used to support ambulation. And the last, we have continuous feeding. It's a prescribed formula continuously given over 24 hours. This is best used for patients who are high risk for GERD or have history of aspiration pneumonia, and those who require jejunal feedings. In our nursing home, we usually use bolus feedings and continuous feedings, but more so in the COVID patients, they use continuous feeding. Initiating and advancing tube feedings. If the patient cannot tolerate an increased delivery rate, feeding rate is slowed until the person adapts. Slower delivery rates are better tolerated, especially in patients who are critically ill, patients who have undergone an extended periods of bowel rest, or and a patient who has had a new tube placement. We got to be very watchful because they cannot tolerate. They are trying to adjust to the new system. How do you assess tolerance to tube feedings? You can check the stool amount and the frequency daily. You need to check the gastric residual volumes, are also known as GRV, every 4 to 8 hours, depending on the condition of the patient. American Society for Parenteral Nutrition and Enteral Nutrition, ASPEN, recommends if the gastric residual volumes is greater than 250 ml, you need to consider a promotility agent. If the GRV are greater than 500 ml, then it is recommended to hold the enteral feedings and reassess and follow up with the physician. So that's when we usually monitor for all the symptoms such as diarrhea or vomiting. And we stop the tube feedings and talk to the physician and then wait for his orders. You also need to check urinary output every 8 hours. Check the skin turgor every 8 hours, evaluate lab values, look at their electrolytes, look at the BUN, creatinine. Is the skin tenting? Are they able to saturate their depends? We can know if they're tolerating the tube feeding. Adult requirements for water is usually between 30 to 40 ml per kg per day. Enteral formulas usually have 70 to 85% of free water. So you need to you need to take into account the fluids when you are assessing the water needs. Additional water flushes are given to meet needs. Water flushes are given with medication also. Let's look at some tube feeding complications. There are GI complications. So for that, you need to provide appropriate type of formula, assess for infectious illness and malabsorption. Mechanical complications, you need to keep the head of the bed elevated 30 to 45 degrees during feeding and 30 to 60 minutes after feeding. You need to routinely flush the tube with 30 ml of water. Clogging of the tube is commonly seen. Tube migration, the tube can get dislodged. So if the head of the bed needs to be elevated 30 to 45 degrees, otherwise there is a risk of stomach contents getting into the lungs, and then the patients can get aspiration pneumonia. Metabolic complications, for that you need to provide appropriate amount of water and formula. You need to assess lab values. You need to check for feeding tube placement. Transitioning to table foods, transition steps depend on patient's medical condition, type of feeding the patient is receiving. Oral intake should meet 2/3 of the estimated nutrient needs. Typically, we use a calorie count for 3 days just to see where the resident is at. Is he meeting about at least 75% of his nutrition needs through the mouth or orally? Then we wean them off gradually and taper the tube feed off and ultimately discontinue and then give them the oral feeds. Let's look at parenteral nutrition. It is intravenous administration of nutrition, which may include protein, carbohydrate, fat, minerals, and electrolytes, vitamins, trace elements for patients who cannot eat or absorb food through tube feeding, formula, or by mouth to maintain nutrition status. According to the 2014 National Inpatient Survey data, patients receive parenteral nutrition in over 290,000 hospital stays. Candidates for parenteral nutrition are patients with severe GI bleeding, intestinal obstruction, short bowel syndrome, severe malnutrition, and intolerance to enteral nutrition, paralytic ileus, or intestinal paralysis. There are two types of parenteral nutrition, PPN, or peripheral parenteral nutrition. Nutrients are supplied via peripheral veins. And candidates who are requiring parenteral nutrition or for only short-term nutrition support, venous access is through central veins. And candidates who require long-term parenteral nutrition get their nutrients through venous access. Just wanted to show you a picture of PPN here. You see the tube going into the peripheral vein. That's the PPN, and the TPN directly goes into the central vein from the bag. The different kinds of parenteral solutions, they are often prepared by the pharmacies located within the healthcare institutions. Solutions are typically customized according to the patient's needs. They have different concentrations. Amino acids are usually in 3% to 20%. They contain essential and non-essential amino acids. Carbohydrates are the main source of energy. Glucose is usually given. D5W, 5% dextrose in water, or D5NS, that's 5% dextrose in normal saline. They have a limited shelf life. Lipid emulsions supply essential fatty acids. They usually come in 10, 20, 30% solutions. All this depends on patient's needs. Fluids and electrolytes. Patient's fluid needs to be adjusted according to daily fluid losses and hydration assessment. Sodium, potassium chloride, calcium, magnesium, phosphate, the electrolytes should be given. Also included are vitamins and trace minerals. Medications are added directly to parenteral solutions or infused through a separate port in the catheter. Parenteral formulations are in either 3-in-1 solution or 2-in-1 solution. They contain dextrose, amino acids, and lipids. In 2-in-1 solutions, they usually are dextrose and amino acids are given as lipid emulsions is administered separately. There are again complications for parenteral nutrition. The catheter-related air embolism, blood clotting at catheter tip, clogging of catheter, dislodgement of catheter, improper placement, infection, and sepsis. Metabolic complications include electrolyte imbalances, gallbladder disease, hypoglycemia, liver disease, metabolic bone disease, nutrient deficiencies, and refeeding syndrome. To manage hypoglycemia, we need to be giving them insulin along with the parenteral solutions. Avoid overfeeding, rapidly infusing rates, restrict the amount of dextrose in the solution. To manage hypoglycemia, we need to taper off over-infusions over several hours before discontinuation. Hypertriglyceridemia, you need to reduce or stop lipid infusions. To refeeding syndrome not to occur, you need to advance slowly. Monitor electrolyte and glucose levels when malnourished patients begin receiving nutrition support. You got to initiate energy needs at half. And to manage liver disease, you need to avoid giving excess energy, dextrose or lipids, which promote fat deposition in the liver. You need to monitor enzyme levels. Gallbladder disease, the only possible prevention is to initiate oral feedings before problem occurs. The treatment can be gallbladder removal, or medications need to be adjusted or given accordingly. Metabolic bone disease, parenteral nutrition adjustments need to be done, nutrient supplements need to be given, medications and physical activity is to be done accordingly. So I'll touch upon our COVID-19 pandemic in older adults. COVID-19 pandemic has disproportionately affected older adults. More than 5.3 million confirmed cases in the United States. Hospitalization is 5 to 13 times higher than in those aged 18 to 29, and death rate is 90 to 630 times higher according to the CDC. Approximately 2/3 of older adults are either at risk of becoming or are malnourished. Protein-calorie malnourishment is related to hospital stays, are 5 times more likely to result in death. Effects of COVID-19 on nutrition status of older adults. Common changes associated with aging, we all know, is loss of appetite, loss of sense of taste, smell. They can't smell the food, they can't taste the food, limited ability to chew or swallow. Their diet changes, the diets are pureed. They would want to eat regular diets, but they cannot swallow. Use of multiple medications, polypharmacy, again, interferes with taste. Functional and cognitive limitations can affect diet and nutrition. Acute conditions such as those requiring surgeries or intensive care stays, chronic diseases such as cancer, diabetes, heart disease can result in changes in nutrient intake that can lead to malnutrition. Majority of the hospitals and nursing homes have implemented the American Academy of Nutrition and Dietetics and American Society for Parenteral and Enteral nutrition characteristics and documentation of adult malnutrition. This diagnostic approach includes physical assessment of muscle loss, fat loss, and the presence of edema. Typically, what we use is a comprehensive nutrition assessment that's done by the registered dietitian. But now it's different because many of the dietitians are working remotely, which limits physical or visual evaluation. Oftentimes, the RDs need to collaborate with the interdisciplinary team to assist with physical assessment of muscle or fat loss. We, in our nursing home setting, we have a separate COVID hallway unit to contain the infection, not to spread. So only certain staff members, nursing staff is allowed to go in, and rehab staff is allowed to go in. So they usually are there working with the patients. Any other person who has to get in touch with the resident or the patient cannot directly go. They need to collaborate with these staff. So what the dietitians usually do is we contact the nurse manager, physically go to their office or call them and talk to them and see how the resident is doing. Sometimes the dietitians call directly the rooms of the residents and get their weight history, diet history, and get our information for our assessment. And if the resident has dementia, then that's a different ballgame. We need to talk to the staff or the family members. The mini nutrition assessment is a screening tool specifically designed and validated for older adults. It is used in outpatient, nursing homes, and community settings. Just wanted to share with you the mini nutrition assessment. It has 6 characteristics. We see that we have to ask them first if their food intake has declined over the last 3 months. We ask them for loss of appetite, digestive problems, chewing or swallowing difficulties, weight loss during the last 3 months, mobility. Are they ambulating? Are they chair or bed bound? Have they any psychological stress? Or do they have any acute disease? Do they have any neuropsychological problems? What is their body mass index and the calf mesh circumference? So depending on the score here, we assess, and then we find out if the resident is malnourished or is at risk for malnutrition, or are they of normal nutrition status. Let's look at nutrition therapy for COVID-19 patients. Patients who are unable to eat by mouth or unable to consume enough to meet nutrient requirements should be prescribed nutrition support. In our nursing home setting, we did not have any tube feeders, but we had some tube feeders from the hospital, and they transitioned to table foods very quickly. ASPEN Society guidelines recommends patients on ventilator support. They receive enteral and parenteral nutrition if oral nutrition isn't tolerated. ASPEN has developed nutrition recommendations for those patients specifically with COVID-19 who require ICU care. For those patients not intubated but hospitalized, all efforts should be made to provide high-quality diets with oral nutrition supplements. Recommendations include staying hydrated, eating a high-calorie, high-protein diet, using oral nutrition supplements, and weighing yourself daily. To rehabilitate muscle mass, exercise program is recommended as well. As you all know, COVID-19 patients become cachectic. They lose the muscle mass. They become skinny. So for that, you need to enroll them in a good exercise regimen to build their muscle. Nutrition and hydration are key to recovery. Symptoms, as you know, are fever, cough, shortness of breath, accompanied by fatigue and loss of appetite, loss of sense of taste and smell. Fever is associated with loss of fluids and increased metabolism, leading to dehydration and increased calorie requirements. You need to replenish them with lots of fluids. You may not have the sensation of thirst, but it is important to replenish the body with fluids. This is not common only with elderly patients or residents. It's even any COVID-19 patients need to be given a lot of fluids. Protein and calories are important to protect against muscle loss, especially if you're bedridden. Let's look at the food requirements. You need to be giving them about 3 quarts, 3 liters of fluid per day, drinking fluids every hour, 2 to 4 ounces every 15 minutes, giving them clear liquids, oral rehydration solutions, sports drinks, beverages with extra calories and protein. You can be given. Calorie requirements are usually between 2,000 to 2,500. You need to account for more than the normal diet because of increased stress. Concentrated sources of fats are butter, margarine, sour cream, cheese, avocado. Foods can be fortified. For example, oatmeal can be fortified. Cream of wheat, breakfast cereals can be fortified. Puddings can be fortified. Milk can be fortified. The staple here is mashed potatoes. So we mash up the potatoes with sour cream and butter to make it more palatable. Protein requirements are between 75 to 100 grams. 10 to 14 ounces of protein sources can be given. Eggs, as we know, has the highest bioavailability of protein. Milk, peanuts, nut butters, almond butter, peanut butter, cheese, and protein shakes. Whey protein can be added to the protein shakes to increase their protein content. Milkshakes, for example, ice cream milkshakes, fruit smoothies, including full-fat milk and yogurt can be given. So what we use is fortified Magic Cup milkshake. We use Magic Cup, the supplement that I talked to you about, add milk to it and make it more palatable and relishing and accepting. What we did was for the last 2 to 3 months, we've been giving them smoothies. We have been giving them milkshakes in between meals just to supply them with extra calories and protein. And they need not be given in a large quantity. As you know, elderly cannot drink or eat large amounts. So small quantities, a half a cup, 120 ml is enough for them. So if you give them smaller amounts, it's well accepted and tolerated. And fortunately, we did not have significant weight losses in our nursing home. Eating small amount frequently, that is essential. Food is medicine when you're ill. We all know that. Take-home messages: nutrition supplementation reduces the risk of complications if given to severely malnourished patients. A clear understanding of body's energy, fluids, electrolytes, and micronutrients is essential. Whenever the gut is available for use, use it. Parenteral nutrition should be reserved for the patients in whom a clear contraindications for enteral nutrition is present. Infection control prevents or stops the spread of infections in healthcare settings. Frequent hand washing, wearing PPE, and following protocols is a must. Thank you. And Sairam, if you have any questions, please email me at marthi.aparna12@gmail.com.
Thank you very much, Madam Aparna, for sharing your expertise with our viewers. In spite of a busy schedule, Madam has obliged us by sending a recorded talk for the presentation. Madam had brought insight into various supplements and special feeding methods used during therapeutic condition. Madam emphasized the oral nutrition supplements can be a boon or a bane, depending on the patients, and fortified foods are the first intervention used in all the nursing home settings. They are acceptable easily by most of the residents, and nutritional status should be monitored for patients to be on nutritional support. Madam also highlighted about tube feeding, and it is generally used when the gut is functioning. If the gut is not functioning, the next step would be parenteral nutrition. Therefore, the COVID-19 patients with mild symptoms are on the road to recovery with oral nutrition supplements. So when the symptoms get worse, nutrition support comes into play. To sum it up, Madam highlighted that COVID-19 patients needed adequate calories, proteins, minerals, vitamins, and fluids. Finally, infection control with medication and diet therapy coupled with mental, psychological, social well-being can lead to speedy recovery path for patients. Thank you very much, Madam, for being with us. Any queries, please write to marthi.aparna12@gmail.com.